4th of November, and welcome to really a Snowdome update about COVID and COVID vaccinations and COVID treatments. What I'd really like to talk to you about this morning is what's worrying people out there. Things have changed enormously in the last 6 months. And, I was just talking before with Mandy from Snowdome that things have really been enormously different in the last 12 months when I did the last presentation, when we talked about the potential for the third wave. And what are the big questions that are out there now? Well, first of all, what my patients are asking me and what I'm spending a lot of time on is talking to them about the third vaccine, or otherwise some people are calling it the booster vaccine. And I think that there is a difference, but really the concept is that a third vaccine is not necessarily waiting for the waning of the second vaccines. We all know that the second vaccine will wane, and it will vary depending on the age of the patient. It will be different for an 80-year-old versus a 20-year-old, but it will wane and people will need top-ups over time. But what the third dose is doing is actually like the second dose, it's boosting it up. So it's like a stepwise effect. So you can actually get the third dose early, around 2 months after the second dose. And that's generally what we're recommending for our patients whose immune system is suppressed, and it is available for patients with suppressed immune systems, patients who've had stem cell transplants, and for patients who are getting certain medications that are suppressing their immune system. So speak to your doctor. You are eligible. I would strongly recommend you look at getting that third dose. You don't have to wait 6 months. The types of vaccines that are available, a third AstraZeneca, if you're in that age group, is feasible. But generally, there has been data that has demonstrated that using the mRNA vaccines on top of previous AstraZeneca can be effective and may in fact be a little bit more effective. So that's the Pfizer and the Moderna. You can get the Moderna from your pharmacy very easily with the appropriate paperwork from your doctor. So within 2 months, Moderna, Pfizer, generally get that top up, it will boost you up. So beyond the vaccines, what also has happened is treatments. So right now the TGA approved a drug called sotrovimab, which is an antibody which actually blocks where the virus, the COVID virus, binds onto the surface of the mouth and the nose, etc., where it reproduces, the so-called ACE receptor, and it binds to the spike, and it blocks it right there. And so if you get COVID, in other words, you get someone coughs on you at the lineup of the IGA, or you get it at the service station, and suddenly you get tested and boom, you're COVID positive, call your doctor, call your specialist, because we can get access through a variety of hospitals, an outpatient infusion for 1 hour, and it treats COVID. It reduces the risk from a 5% admission into hospital. If you're double vaxxed and immune suppressed, we would say the risk of getting into ICU is about 5%. That treatment drops it to less than 1%. So any patients that are eligible, it really has a positive impact. I've treated 2 patients in the last week. One was coming in for their 8th dose of rituximab. He had a swab coming into hospital, routine, was COVID positive. It turned out that 4 other members of the family who were totally asymptomatic, all double vaxxed, they all had COVID. He had minor symptoms. We infused him, 14 days of quarantine, perfectly well. The only one who was a bit unwell was his youngest daughter, who was single vaxxed, but she'd only been vaxxed a few days beforehand. And so it didn't have its full impact, and she was a bit unwell. But there's 2 stories to that. First of all, these drugs are going to be very effective and make people more bulletproof, and more are going to be coming. You're going to start to see them. They're going to be more routinely available. Early detection, testing. It has to be used within 5 days of the symptoms. So please, if you've got symptoms, go and get tested. If you're positive, there's a treatment. So don't delay. If you delay too long, then the replication in the head and neck, in the mouth and the mucosa, etc., is too much for these drugs to be effective. But we are going to see more and more. The second take-home message from that is that patients are feeling pretty well. None of the patient, none of the his wife or children felt unwell when they had COVID, and we're going to start to see more of that in the population where people are living with it. I've got another family who all got COVID, and the patient knew she was going to get COVID because her husband and 2 children had it, but she was double vaxxed and she was well. She got through it. So I think the level of anxiety needs to come down, and we will start to feel more comfortable about it. So I think it is going to be a change of the severity, but we've got a tough November, December to come, because there's going to be a lot of people who are still going to end up in ICU. It's going to be tough on the hospitals, and it's going to cause a bit of chaos in terms of outbreaks at different places. So what's happened in the USA and Europe? Another question, and that's really been very interesting. Basically, there is 3 groups that we consider high risk for COVID in terms of patients with blood cancers. Patients with chronic lymphocytic leukemia who are in the midst of treatment, who have had either antibodies or ibrutinib or acalabrutinib or venetoclax. There's a mixture. If patients have a diagnosis of CLL and are being watched and not treated and haven't started treatment, generally fine, not really that sick. But early on in the treatment, because CLL and the combination do suppress the immune system, people need to be very wary. Particularly, again, age is really important. The second group is the patients who are getting the monoclonal antibodies against CD20, particularly rituximab. Once rituximab stopped, about 6 months later, the immune system really does start to improve. There's data around that, but we're still getting more and more information about that. But ultimately, if you're getting rituximab, you are at risk and you need to be careful, and I'll come back to that. What about myeloma patients? Well, myeloma patients, if they're in that smoldering myeloma pre-treatment, generally very safe. The risks are not major. Patients who've had their transplant and are a year out, generally not a major issue. This is the data that's come from overseas. But if you're in the middle of therapy, then there are risks of getting significant COVID and the vaccines not working well. So there's 2 issues. One is the effectiveness of the vaccine and the fact that COVID can be worse. But at the end of the day, it's predominantly age that impacts in terms of the severity of the COVID. So how do you know if the vaccines worked? And that's a question that really is the hardest to answer. People are saying, is it safe to me to go out in the public? Is it safe for me to go and visit my grandkids? Is it safe to me to go to a restaurant, go to the cricket, go to the races, etc.? Well, I think the answer is that if you're in those subgroups, you need to be very wary. You need to use all of the things that weapons that we've had, which is masks, social distancing, having your bubbles. What about things like rapid antigen testing? Well, that can be helpful too. So these are now going to be available in supermarkets, etc., where you can swab. So perhaps if you're not sure if the family's okay and you're a bit anxious and somebody's going to be staying with you a while, consider getting doing a rapid antigen test. And if they're negative, the likelihood becomes less. I think we're going to start to see how they're used. They're used all the time in Europe and in America for traveling. People are having their swabs. And in fact, they're isolating for the 10 days before they take their holiday so that they don't get kicked off at the airport when they come back positive, but they do their testing and then they get on the plane. We're going to start to see changes in how we can use that. But if you're a year out after transplant, you're double vaxxed, then you're pretty likely to be okay, but still use all of those other maneuvers to try and avoid it. Again, age and other comorbidities, obesity, renal function, they impact on your sickness when you get COVID. So it is very, very individual. So Brett Sutton said the other day, all of us are going to get COVID. Well, it's probably true. But what we have to look at is, can we buy time as we get a stronger support mechanisms to get us through as patients who are immune suppressed? And so what I mean by that is that double vaccinated, triple vaccinated, and then hopefully we'll start to get better testing. At the moment, we don't have great tests, so-called neutralizing antibodies, to assess neutralizing antibody tests to assess the effectiveness of vaccines. It's really tough to work out the effectiveness of a vaccine, particularly a COVID-like vaccine. We can't just do a simple blood test. So we have to wait for better testing. It will come. We're getting more treatments, as I spoke to you about. Sotrovimab is the current treatment, but there's going to be tablet treatments for people who are diagnosed. So we're going to get better. We're going to be able to cope with it. But I think the humps into the road are for patients who are significantly immune suppressed. November, late November, December, January, there's going to be a spike and an increase. There's going to be the people in front of you at the line, at the market, at the supermarket, at the service station, could potentially be COVID carriers. So you need to beware. So be careful, use all the other ammunition we have. Let's get through that period. And then we will move into a safer period where it's less. Talk to your doctor about treatment modifications that may be required. Transplants are still being put on hold for various reasons, for various indications, until we get through this period of November, December, where the hospitals are going to be seeing a lot of COVID patients simply because of the numbers going up and the proportions. So we get through that. And then into the next year, it's going to become easier. We're going to have all of those things that are available to us. So, if you've been diagnosed with a blood cancer, you're not getting active treatment, you're being observed, or you've gone through all your treatment, you're being observed, make sure you're fully vaccinated. Make sure your family's fully vaccinated. There's no excuses. I have zero tolerance for non-vaccination. I don't give any exclusions for patients. Haven't given one, and I'm quite proud of it, because there really are exceptions. You need to make sure that your family's vaccinated, and then they won't be stronger carriers. They won't bring it home. Think about using the rapid antigen test. And speak to your doctor, and start enjoying it. And updates will come again in a few weeks. Thanks very much.